Now, I know who you've all been waiting for, Dr. Stephen Loyd. Dr. Loyd is the chair of the Opioid Abatement Council in Tennessee. He serves as the vice president of the Tennessee Board of Medical Examiners and previously served as the opioid czar for Tennessee's Department of Mental Health and Substance Use Services. He has been named the Advocate for Action by the Office of National Drug Control Policy, and Dr. Loyd's personal journey with addiction recovery is the basis for the Hulu series Dope Sick. You know, I've seen and I met with Dr. Loyd. I've heard him speak. He's such a dynamo. He is so passionate about his own recovery as well as helping others that are struggling with addiction. And I know you are really going to enjoy what he has to say today. So without further ado, please welcome Dr. Loyd.
Thank you. I'm going to go off script, and that's something because I don't have a script, a little bit, because this is the first talk that I've done since a week ago, Tuesday night. And I'm going to talk about innovation, and I'm going to talk about addiction recovery, and I'm going to talk about some ideas we have around that I think can help hurting people. But the biggest thing, guys, that we have to overcome is the stigma around mental health issues and SUD. It's not anywhere close. And the reason I want to talk about this is because I come in here wounded today. I was sitting over here as Dr. Coffell was talking about me. I don't know if I can live up to it. The place that I work, Cedar Recovery, we wanted to take a medication-assisted treatment clinic into a rural area in Tennessee. It's the second worst area in our state outside of Northeast Tennessee, where I'm from. We're the second worst state in the United States for overdose deaths right now. Two of our metropolitan areas, Davidson County, which is Nashville, Shelby County, which is Memphis, are in the top 10 for overdose death rates in the United States. We have a serious issue, and it's a rural issue, a huge rural issue. So we wanted to take a clinic there, we wanted to hold a town hall and explain to people what we do and how we want to help in their community. And I was born in 1967, so I guess I was born into the Jim Crow South. I don't remember much of it, mainly because of my father raising me. But imagine what I experienced last Tuesday night was about as close to the Jim Crow South as I'll ever be. I was threatened. I was yelled at. I was screamed at. I was called evil. We don't want, quote, these people coming in to our little community. And they're all led by three pastors, believe it or not. And they told me what I was seeing was not stigma. They told me what I was seeing was passion. Well, you can name a pile of crap a rose. It is still a pile of crap. And that's what I was seeing that night. And it wounded me. It wounded, I realized part of that's my ego. But what I really felt bad about were the threats, the personal threats. They threatened to burn the building down that we wanted to buy. And the long and short of it is that we couldn't put our staff at risk to go there. And we knew that. I don't mind going there. I'd build it in their front yard and operate it myself. I got no problem with that, but I can't ask my staff to do that. And so the long and short of it is that we had to pull out, and my phone has been blowing up over the last 3 or 4 days from people that live in that community, one, apologizing for the behavior, and two, telling me that they had benefited from medication in their own recoveries, and if it wasn't for that, they would be dead. And guys, we got to remember, when we throw things out there like that and we stigmatize what we do in behavioral health and mental health issues, there are people out there that need help that won't step into the process because they're scared of being stigmatized from it. And guys, it has worn me out. It has worn me out. And I wanted to get that off my chest this morning so you know where I'm starting from. I promise I'll get better. So I want to address the dope sick thing before I get into my talk. So it was a really neat thing to get to do. My friend Beth Macy wrote a New York Times bestseller called Dope Sick. She's an investigative reporter from Roanoke, Virginia. And I met her when she was writing that book. We became friends. My picture's actually in there. She said she found me because she was out there and all she saw was despair. And she kept asking people, is there any hope out there? And she said, your name came up a bunch. And so that's how I met Beth. And I'm glad my name came up with hope because that's what I want to bring here today. because there is another side to addiction. Okay, it is called recovery. And there's a lot of people living in recovery. There's more people living in active recovery right now in the United States than are active addiction, but it's not celebrated for a lot of different reasons. So best book goes on and becomes a New York Times bestseller. She calls me up a couple of years later. She goes, "Hey, Steve," she said, "they want to make my book into a Hulu series." And my first question was, what is Hulu? And so I didn't know what Hulu was. And she said, "It's like Netflix." I said, "Okay, I get it." And she said, "We're going to rotate it around a fictional doctor. It hadn't been cast yet. And we would like to use you to help us with some of the scenarios we put our doctor in who develops his own addiction." I said, "Sure, I've got experience with that." And so we started meeting. This was during the pandemic. The writers were all out in California. Danny Strong, the producer, and the other writers. And then Beth was in Roanoke, and I was where I live in Nashville. And the first thing I noticed is that the writers were all about 15 years old. It was past their bedtime some of the nights when we finished. It was unbelievable. But we kept going through scenario after scenario that weren't realistic. And finally, Danny Strong said, "Steve, why don't we just use your stories?" And I said, "Well, the main reason is I'm going to take those to my grave." And I thought about it for about 5 seconds. What if you had a disease you never saw anybody get better from? What would that be like? You didn't have any hope. You didn't know that there was a way to come out on the other end and not have to live in the shadows. Because of what I do, I have MD after my name. I was a doctor whenever I had my addiction issues. I decided I wasn't going to live in the shadows. I wasn't going to remain anonymous. I was going to live out in the open. And I've done that my entire recovery now for a little over 19 years. And so that is where the stories in Dope Sick came from. There's very little Hollywood in it, in case you're curious. From episode 3 on, the Michael Keaton character is actually me. I tell people all the time, he was a hack before he got a hold of my role, and I shot him to start him. Batman wasn't that big a deal. So, but I thought he did a great job with it. And the series actually won 2 Emmys. 2 things that didn't happen in real life. One is because of the grace of God and a lot of really, really good people around me, I haven't relapsed. And the second thing is I never bought a school bus. For those of you who've seen the series, I should have, as many people as I've carried to treatment, but I never bought a school bus. So that's a little bit of the story behind Dope Sick, and I'm going to show you the power of it. Best book was a New York Times bestseller. I think it sold about 500,000 copies and counting. Pretty good. You know how many people seen Dope Sick? 20 million. There's 20 million people seen Dope Sick. And I can't tell you how many doors that opens for folks when they realize I was connected to it. The patients that I have whose parents have decided it's okay for them to come and see me because they saw that. So media plays a huge role in this, and it opens doors for folks. So what I want to do for you today is talk about a potential opiate abatement model. I'm going to tell you how I came to this conclusion. I'm not the only person. There's other people that have come to this as well. But guys, we have to tie our system of care together. We need a system of care that no matter where you touch the system, you get the treatment that's right for you. And I can tell you right now that doesn't happen. It doesn't happen in rural Tennessee, and it doesn't happen in Florida either. Guarantee it. The treatment you wind up getting is based on what treatment that the provider that you wind up with, however you wind up there, provides. That's it. That's how it works. The number one thing we have at our disposal in keeping people alive with opioid use disorder is medication. Yet way less than half of the facilities out there even offer it as an option to their patients, and it has a 70% mortality benefit. What does that mean? That means that 70% of the people that would have died otherwise won't. Name me another drug that has a 70% mortality benefit. Anybody. I'll save you some time. If you don't count insulin, you can't. Okay? Yet we don't even mention it to families who are busting their bank. They're mortgaging their homes. They're draining retirement accounts to try to take care of their kids. And we never mention the one thing that can keep them alive. And guys, I can't treat dead people. Nobody in this room can. And so the system of care I'm going to present to you is what I think is logical. I'm going to talk a little bit about the use of something called systems dynamics and artificial intelligence or machine learning to help us in that process. So I started to realize early on in my own recovery that there's really 2 different pathways to recovery in the United States. There's the pathway for people who have resources, and then there's the pathway for everybody else. So back in the early 2000s, in my chief resident year, my last year of training in Johnson City, Tennessee, in internal medicine, I was on my way home from work one day, and I didn't like my life very much. We didn't have work hour restrictions. I was working over 100 hours a week. I was the chief of the hospital, so I had all these residents under me. Back then, the attendings were, few and far between. We didn't have a ton of interaction with a lot of them, so we were basically on our own. A very stressful life. Didn't like my wife very much. I had 2 young kids. A very tough time in my life. I was overworked. I was burnt out. I was stressed. I was anxious. And on the way home from work one day, I pulled up at a red light in my hometown where I was training, opened the glove compartment of my truck, and there were some old Norcos in there. Norco is hydrocodone and acetaminophen. You know it as Vicodin, Lortab. And I looked at those, had them from a dental visit months before. I just chucked them in my glove box, didn't think anything about it. And I picked one of them up and I said, my patients take these things all the time. So I broke one in half, 2.5 milligrams of hydrocodone, threw it in my mouth. By the time I got home 10 minutes later, suddenly my job wasn't so bad. I wasn't as worried about the future. I liked my wife better and my kids were better behaved. Well, what changed on that 10-minute drive? Nothing. I had no idea that my personal history of addiction with the inability to really consume alcohol at any point in my life, my family history of addiction, 18 first cousins on my line in our family tree, 4 of us died of drug or alcohol overdose before age 40. And more importantly, my history of childhood trauma, physical and sexual abuse. I had no clue sitting in my truck at that moment that those risk factors put me at markedly increased risk to let this little bitty thing that looks so innocent take over my life. No clue, because we don't learn any of that in med school or residency. And so within 3 years after I got out, went into university practice, academic track. I'm teaching in medical school. I'm running a hospital practice, running an outpatient practice. And I got up to 500 milligrams of OxyContin and 8 milligrams of Xanax every day. And guys, I wasn't living underneath the bridge. I was seeing patients in the ICU, medical step-down units, 3 of the 4 years that I was using and practicing medicine. The students named me the best teacher in internal medicine 3 of those 4 years. In the 4th year, I was named by the graduating class as the best teacher in the medical school out of all the faculty. And I had used the whole time. During that graduation ceremony that I was honored, I used 160 milligrams of OxyContin in the bathroom. That's where I was. And I got help. My dad intervened on me. I'm a doctor. You don't kick doctors to the curb. We cost too much money to make. Taxpayers' dollars paid for my education. It's better to rehab me, put me back in my job than it is to try to make another one of me. And I got world-class treatment. I went to Vanderbilt University for 5.5 days of detox. There were 24 kids on my floor. And I'm telling you kids because they were kids. Guys, they were young. None of them knew I was a doctor. I weighed 175 pounds. I looked like death. Do you know how many of those 24 people got to go to a rehab facility when they left that 5-day detox? Anybody want to guess? You're looking at him. 1, me. Rest of those kids went back to the street, every one of them. And I got to know them while I was there. The little girl that was next to me had HIV. She was an intravenous user. She worked as a prostitute in Printer's Alley in Nashville. And before I left, she came up to me and she said, "Steve, I wanted you to see what I look like when I'm clean." Her words, not mine. And it was a picture of her at her junior prom at Mount Juliet High School just out of Nashville, and she looked like an angel. It was important for her, for me to see that. I didn't think of her. I don't go a day without thinking about the kids on that floor because I'm the only one that got treatment. The rest of them went back to the street. And that's when I started to realize, oh, goodness, not everybody here's going where I'm going. I assumed we were all going to the same place. Yet I was the only one that got picked up by a psychiatrist in a really long BMW and driven somewhere and got help with my physical, sexual abuse, learned about addiction, and put me on a pathway to recovery. What's the success rate for doctors in the recovery process? Anybody know? Come in at day 1 at 5 years. What percentage of them are back in their job and clean and free of everything? Anybody got a guess? It's about 78 to 95%. All right. What's it for everybody else now? 10, right. What's the difference? The system of care they step into. System of care they step into, and that's what I want to talk about because there are ramifications for the system of care, guys, and it's killing our kids. We got 107,000, a little over 107,000 deaths. So last year I looked at it, the equivalent of a 747 airplane crashing and burning, killing everybody on board every 36 hours around the clock for a year. Yet you almost never see anything about it because of shame, stigma, and people don't want you to know what's going on inside their house. So when I was the opioid czar, and by the way, Dr. Caulfield, when you said that, I really miss being called a czar. Although the only czar I ever heard of got his head chopped off, so I may want to pull that back. But when I left the state of Tennessee and went back into private practice, I was really interested in treatment of the pregnant patient. When I first got involved in addiction medicine, you got to remember, guys, I'm self-taught. I'm not trained. I didn't get to go to a fellowship program. University of Florida has a great one. I didn't get to go to that. I'm an internist. I work in the hospital. That's what I do. So everything you're going to see today, I'm completely self-taught. But I got really interested in pregnant women right off the bat because I was around in the addiction medicine circles. All I heard about was pregnant women this, pregnant women that. They're bad. They're terrible. They do this to their kids. We've got to lock them up. We've got to take their babies. I mean, it was awful. And so I raised my hand in one of the conferences one time, and I said, what kind of treatment programs y'all have for them? So, we don't take them. I said, what? So we don't take them. I said, we just sit here and run them up a pole for an hour, and nobody's taking them. I said, no, too much liability, too much risk. I said, all right. I said, what about if we get a young lady and she's in treatment, and then we find out she's pregnant? That can happen for sure. Happens a lot. So what do you do then? What do they do? Anybody know? Kick them out. Kick them out. Name me another disease where we kick patients out, by the way. I don't know. I mean, if we applied the same thing to heart failure that we did addiction, we would take grandpa who ate too much Christmas turkey and the day after Christmas comes in short of breath into the ED. If we treated him like an addiction patient, we would yell at him, tell him he didn't want it bad enough, and we'd kick his ass out. That's not what we do. We go back, we re-educate him on salt and intake and weighing themselves daily and diuretics, right? Meeting with kindness and love. But addiction, it's okay. They deserve it, by gosh. They brought it on themselves. We'll show them tough love. I've never seen tough love work, not a single time. I haven't seen it work, so I'm not going to do it. So when I was with the state, I was very interested in pregnant women. I learned everything I could about them. I will tell you a little secret here. If you want to be an expert in something, pick something nobody else is doing. I said, you can be an expert in it right off the bat. And so I learned how to treat pregnant women. I've treated probably, close to 1,000 by now. Now we don't do it as much as we used to because a lot of other people do it. But I wanted to go to a place, and this wasn't planned, Kevin. I wanted to go to a place when I left the state that would allow me to open an inpatient program for pregnant women. And the guy sitting over here to my left, and I didn't know I was going to see him today, his name's Kevin Lee. He owned a treatment facility in Murfreesboro, Tennessee called Journey Pure. And Kevin met with me and said, yeah, we'll allow you to do that. So Kevin, I appreciate it. You took a chance. And this is our second patient you see on the screen. Her name is Brooke. And if there's any lawyers in the room, I've got all the signed stuff to use this, by the way. All right. So Brooke is the toughest patient that I've ever had. And guys, I've been doing this a while now. Brooke is a certified welder. I knew Brooke for 2 weeks before she called me anything other than MFer, and she wasn't using the initials. So Brooke is living in Ohio. She is in her mid-20s. She is using intravenous heroin, fentanyl, and the other drug, methamphetamine. And she finds out she's 8 weeks pregnant. She goes to her mom and says, Mom, I'm pregnant. It's her first child. I need help. They got on the computer. They Googled doctors in the United States that would take women who were using drugs and pregnant. My name popped up. They called me, and I told them to bring them to Murfreesboro, Tennessee. Brooke's mom, Angie, took this picture about 7 hours before I met Brooke. Brooke did great. All right, Brooke did great. Brooke is, I'm sorry, guys, this is just me. I am a East Tennessee redneck. Brooke's a badass. She's a badass. Why did she call me MFer for 2 weeks? She wanted to see if I'd run. I don't run. I showed up every day, and I walked in the house one morning, and she was in there having breakfast. She goes, good morning, Dr. Loyd. And I thought, oh, my goodness. Right? And she never called me MFer again because I didn't run. One good thing about pregnant women, you can scare the heck out of insurance companies with them, and I did. And I kept her, and I kept her, and I kept her. We took her insurance. She didn't have to pay cash. We helped her with her childhood trauma, which I can tell you my Sunday school class don't want to know about. All right. But Brooke had this thing back in Ohio that she wanted to get back to. It's something called a baby daddy. Now, when I first started doing this, I had no idea what a baby daddy was. And you know how when you get down the road and you've played like you know what it is, and now it's been so long you don't want him. I did that. And so my kids told me about this app on my phone called Urban Dictionary. So I looked it up, so I know what a baby daddy is. Brooke's baby daddy is back in Ohio. Brooke wants to go back to Ohio. She had a great recovery community. She had me as her doctor, not me being special, but me being a guy that didn't charge her cash to take care of her addiction. We were getting her help with her underlying childhood trauma, the drivers of her addiction. And so Brooke wanted to go back there, and she did. She delivered her baby, Ava. You can see Brooke in this picture. I want you to look at her. Compare those first two pictures. Difference, 32 weeks. I get to watch this all the time. It's the most satisfying thing in medicine. I get to watch this all the time. Brooke is a dime. Y'all know what a dime is? It's a damn 10. Brooke is a 10. Look at her there. They don't even look like the same person, but she's struggling. So I'm talking to you about systems. Brooke has 2 felonies. She's a certified welder. She should make $50 an hour at least. She has 2 felonies. Her felonies were for possession with intent to resell, which is based on how much you have on you. But Brooke was not a drug dealer. She's using heroin and fentanyl. Her tolerances are so high, her daily amount is enough to get her busted for intent to resell, even though she wasn't a dope dealer. We hung 2 felonies on her. She had a public defender. I can tell you if it happened to my kid wouldn't have a sticky note in their permanent record. But Brooke can't afford that kind of defense. So instead of being able to make that and raise Ava, she's living with her mom, working in a mini-mart, making minimum wage. She did go back to Ohio. She got on Ohio Medicaid. She couldn't find a provider that would take Medicaid, so she's paying some doctor in the end of a bait shop somewhere to write her medication and not doing anything for her underlying mental health issues and not doing anything for her trauma. Brooke's struggling. Brooke struggled mightily. Brooke got thrown in jail. A jailer and a sheriff who had no medical training, none, no license, nothing, stopped her medication because, quote, I don't believe in it. Really? You don't believe in it? I don't care what you believe in. You're not a doctor. You don't have a license. This is a young woman. She's got a baby. Yeah. When she left, they didn't set her up with anybody for her underlying mental health issues. They didn't send her back to her addiction medicine doctor. On the morning of, I think it was December 13th, 2020, which I think was a Sunday, my phone rang early in the morning. It was Angie. She said, Steve, I found Brooke cold and blue in her bed. This is why systems matter. Brooke's one of the 107. All right, this one's on us. This is a preventable death. So, okay, it's over. All right, she's one of the numbers. Let's move on. I've heard that. There's one way out of this. We can kill our way out of it. So let's kill our way out of it. There's a problem with that. Who's that? That's Miss Ava. Guys, addiction is 3 things. I teach it as a slot machine. When the 3 sevens come on the pay line, that's when the money comes out the bottom. Genetics, trauma, opportunity. That's addiction. So let's look at Miss Ava for a second. Now, Angie, who is raising her granddaughter, Ava, and I talked to Angie just last week. Ava is doing well. She sent me this picture. She's being potty trained. There's her little pink potty. She appears to be very pleased with whatever's taking place right there. Okay? So let's take a look at Ava for a second. What's her genetics? Mom and dad both have SUD. Her first 7's on the pay line. Let's look at her trauma, adverse childhood experiences. Dad incarcerated, mom dead. Her ACEs score is 2. She's only 2. We know that when the ACEs score gets to be 4 or above, our risk for just about everything goes almost straight up, right? And even so-called real diseases like hypertension, diabetes, all different kinds of cancer. If we don't help this child, what are the chances she is in our system in 10 years? It's about 100%. Those of you who work in this field and have worked in it for a long time know that right now you're treating the children of people you treated a decade ago. Y'all know that. We have to get serious about prevention. We have to identify these at-risk kids, and we have to teach them and help them with resiliency going forward, because just because you have the genetics and trauma doesn't mean you have to wind up there. But there are protective factors that we can foster in these kids, but we can't do it as long as we just discipline them and put them in school suspension. If you want to know who they are, ask their first grade teachers. They'll tell you. They'll tell you. So what about me? This is my little family, and I know where I am, and I'm an unabashed University of Tennessee fan, and it's been hard for about 20 years. But this is my little family. And we're going to a game in Knoxville. I was on the back porch of one of my professors' houses, and it looks like the perfectly young doctor and his family. Got my whole life ahead of me, and I'm sorry I can't see the screens good enough to show you all this. But that's my son Heath, my daughter Haley, my wife Karen, and then me. If you look real close at my right pocket, there's a bulge there. And that bulge is not my car keys, and it's not my wallet. What is it? It's a bottle of pills. And so when I look at that picture, I love seeing my kids that age, and I love remembering that time of their life, and I die a little bit inside because I couldn't do anything unless I had that bottle of pills. Not raise my family, not love my kids, not go to the football game and join it. I couldn't do anything, and I couldn't believe it happened to me. I had no clue. I got world-class treatment. I caused too much to kick to the curb. I got help with my childhood trauma. I had a mom who had untreated mental illness. She was bipolar. She also had a benzodiazepine addiction. She was ungodly abusive, not spankings, not discipline, beatings, belts, belt buckles, whips, ball bats, tobacco sticks, ends of shotguns. All right. Me and my sister undertook beatings. When I was 5 years old, the earliest I can remember, my favorite uncle molested me. And when I was a little older, it got worse than that. I had no idea that those things put me at increased risk to misuse this control. Not a blame. It's just a fact. It is a risk factor. And so there I am living this double life, but I step into a treatment system that's designed to put me back to work. I didn't step into a treatment system that put me in jail, hung 2 felonies on me, and then denied me basic medical care. I didn't step into that system. So a few years ago, I got a registered letter in the mail. I don't know about you all, but I've never gotten anything in the mail registered that was good, ever. All right? Except for this one. Our Governor, Bill Lee, appointed me to be on the Tennessee Board of Medical Examiners. Okay, I should be in front of the medical board, guys, not on it. But yet I'm on it. I'm now the vice president of it. All right, I love my work there. I'm the chair of the Tennessee Opioid Abatement Council. We got about $1.2 billion over the next 18 years to try to do something about the scourge that has ripped our state apart and ripped our families apart. And I'm the chair of that. And I'm the chair of that, guys, because I'm a turtle on a fence post. Yeah, I want you to think about that for a second. From Alex Haley, by the way. What's the one thing you know when you see a turtle on a fence post? You know one thing for sure. It didn't get there by itself. Turtle did not shimmy up a fence post. People living in recovery are all turtles on a fence post. Somebody cared enough about them to step into their life and help them and build a recovery community around them. And that's me. That's why I'm in front of you today in Orlando. So let's look at our foundational concepts. 1, addiction's not a moral failure. When I was in front of that group in rural Tennessee the other night, being yelled at and screamed at, I got to a point, and this has got to be something bigger than me, I got to a point where I didn't hear the yelling and screaming, and I started to look at the underlying hurt. I started to see the underlying hurt. How come they were yelling and screaming? Because they had been treated badly in the system themselves. They hadn't been cared anything about. One lady jumped up and says, I went to a clinic and I was there this long and I've got these scars up and down the time. I was sticking a needle in it the whole time. Her providers didn't care enough about her to unbuckle her sleeve and look and see was she still struggling. They just wrote her medicine and put her back out and she paid her money. And that's the way it is most places. And I started to see that. Now, I'm still not telling you that I wanted to go out to dinner with them. Still wanted to go out in the parking lot with a couple of them. But the truth is all that anger was coming from a place of hurt about how they'd been treated by the system. And then the pastors in town had sold them that this was a moral failure. And it is absolutely not a moral failure. It is a disorder of the brain. We know that. Treatment works. All right? And that's my second one. Addiction's treatable. Treatment works. People recover. Everybody in this room knows multiple people in recovery. And if you don't, you know one now because you know me. All right? And I've been doing it for a little while now, and hopefully I'll be able to continue to do it today. And then last but not least, addiction is complex, and the solution is systemic. Guys, we're not going to do one thing that's going to fix this. It's not going to happen. It's got to be a systemic solution, and that's what I want to propose to you. And I want to talk just a little bit about how to potentially use technology to help with that. So here it is. This is our goal. There are referral sources on the left. Biggest referral source for people for SUD or mental health issues is actually the criminal justice system. That should not come as a shock to anybody in this room. Okay? Last, doctors, believe it or not. So there are referral sources on the left, treatment providers, counselors, community support groups, self-directed. What's our goal? Our goal is the far right. Okay, our goal is that happy person who's employed, who has transportation, housing, and social support. Guys, these are social determinants of health. You can't just treat addiction in a vacuum, right? What's the most important thing? You got to have a place to lay your head. So I've got all these housing places around Tennessee. So we provide sober living. And then they give me this list of conditions they need to get it. And I said, hell, if they did all that, they wouldn't need housing. They'd buy their own house, right? Well, they can't be on medication. Why not? Medication is the gold standard. You don't take them. You tell me about God's love, yet you're excluding them because they're doing something you don't believe in. And nowhere in the definition of recovery does it say anything about medication. And I'm a 12-stepper. I go to AA. I know the doctor's opinion written in 1935, just like you do. Right? It doesn't say anything about it. And those 12-step groups don't have any opinion on this. Officially, that's your opinion. Yet we exclude people because they're on medication and we don't provide them housing. How would everybody in this room do last night if you slept on the street here in Lake Nona instead of the hotel rooms you stayed in last night? Right? You wouldn't look as good. Right? You wouldn't be able to do your job as well. So we have to look at social determinants of health. We have to look, you guys, this is Maslow. We can't get to the higher order of need, and guys, until we solve the basic needs. Food, stable housing, right? Transportation. Tell me a job you can have without a car, unless you're living in the inner city and you've got mass transit. You can't. Yet we hang all these things on people whenever they're incarcerated. We put these huge fines on them. We withhold their driver's licenses. Those fines might as well be $1 million because they're never going to pay them back. They stay on probation the whole time. What about turning around and using those fines as contingency management? What if we did that? What if we said, the longer you stay in the recovery process, we're going to knock a little bit off of these fines as long as you keep doing well. And we're going to give you a conditional driver's license where you can take your kids to school and we can and you can go to work. And the longer you stay on this, we're going to keep knocking these fines down until you're paid off. Right? This isn't genius. I told Kareen earlier, right, this is an innovation conference. I'm not an innovative guy. But I've been out there. I've worked in this. I used to think the criminal justice system got all kinds of bad rap. People were in there because they did bad stuff, right? And all the faces I saw were black. So obviously they should be in there, right? And I didn't know about stop and frisk. I didn't know about targeting people of color. Guys, it's just a fact. And I had to open my eyes to it. And we're going to have to open our eyes to it because I was in North Dakota last week. They have a wonderful governor up there. I don't care what your politics are. His name's Doug Burgum. He's actually running for president. He can't win because he's not crazy enough. Doug Burgum and his wife, Catherine, their entire 7 years in office in North Dakota, recovery and addiction has been their platform. They ran a conference called Recovery Reinvented It, and he and her emceed it all day long, and she's been in recovery herself a little over 20 years. And they started looking at the things I'm looking at. And he told me in North Dakota, 100% of the women they have in their state penitentiary system, 100% have SUD. 100, not 80, 100. The men are 85 and he thinks it's higher, and I think he's right. Our jails and prisons are full of people with untreated SUD that want a life like I have. But we're not going to get there as long as we just keep locking them up. Every time I turn around in Tennessee, a rural county who's broke is building a new addition to their $35 million jail every single time. Yet they won't talk to me about ways to help people from coming back in. It's amazing to me. So let's look at the recovery ecosystem. There in the middle are all the things that we need to be doing as we help people, this turtle on the fence post concept. Employment support, case management, peer support. Guys, peers are unbelievable. Don't tell me you can't get reimbursed for them. I don't care. All right, look at your retention and treatment if you've got a peer attached to them. Okay, you're going to more than make your money back just by attaching a peer to them because they're going to stay in treatment because they got a relationship. They're a turtle on the fence post. They say, well, you don't, we can't make money on it. Yeah, you can. Okay, you shouldn't be looking at that anyway. Do the right thing, it'll work out. But I'm telling you, peers are the secret sauce, at least in the outpatient world. And I'd also argue in the inpatient and transition to outpatient. Stable housing, education support, health, physical and mental, and then life skills development. That's what treatment looks like. That's the outcome on the right. So how do we get there? We got to start with what I call survival programs. I can't tell people where I got it. I got it from the Black Panther Party. So Black Panthers in the 1960s, they had their survival programs. They provided breakfast to kids in Oakland, California, in Northern California. And so I love that term that they use. So I call them survival programs. Number one, access to naloxone. We have to, this needs to be everywhere. It needs to be standard issue. It needs to be in your backpacks. It needs to be blanketed across the United States. All right, and if you find somebody down, hit them with Narcan. If they didn't overdose on opioids, it ain't going to hurt them anyway. I used to hit myself with it during talks, and then I got to wondering, I'd done it 4 or 5 times, so I stopped doing it. It doesn't have any effect if opioids aren't on board, and it saves lives. Guys, the first step in treatment, people, is you got to keep them alive. We got to have access to syringe service programs. I get people all the time saying, oh, you're condoning behavior. No, you're not. It's like people that told me you're condoning behavior teaching kids about sex education. When I was 13 years old and they taught me about sex education, they didn't put any ideas in my mind, guys. I promise you I had already had them. Every damn one of them. Right? We got to keep people disease free. You say, well, I'm not an intravenous drug user, or I'm not a homosexual male, so I'm not at risk for HIV or hepatitis C. Yes, you are. You're at risk from it because your risk is directly proportional to the viral load in your community. And if you have a car wreck and the people in your community have donated blood, there is a risk for that. You are at risk. Guys, we do not live in a vacuum. Syringe service programs decrease rates of hepatitis C and HIV. Verlac, you may know what Verlac is? Voluntary reversible long-acting contraception. You have to have access to that to our women of childbearing age. Right? If you want to prevent babies from being born drug dependent, then give widespread access to Verlac. Right? It's not a condition of anything, but offer it to them. Right? We did it in East Tennessee, in Dolly Parton's hometown, Sevier County. We took education programs into our jail of our women of childbearing age, and we educated them. And if they chose, and that didn't have anything to do with their crime, anything to do with their sins, if they chose, then we would give them an injection in their arm that would get them to an outpatient appointment for an IUD placed. Within 1 year, we dropped the NAS rate in that county by 50%, and it's been sustainable, widespread access to voluntary reversible long-acting contraception. Next, increased access to medications to treat opioid use disorder. Guys, there's a million different pathways to recovery. My job as a clinician, as a physician, is to find the path that's right for the person right in front of me, not the one I did. They may not have access to the one I did. They may not be on a spiritual plane where maybe they've been harmed in their church. Guys, churches harm people. You all know it too, right? So we have to look at the path that's right for them. We have to have increased access to MOUD, support during pregnancy and postpartum, and then last but not least, expand services for NOWS, neonatal opioid withdrawal syndrome, right? Because the big deal is that the kicker for the baby is not going to be the time they're spent in the hospital. It's going to be the environment they go back to, that they're going to live in for the next 18 years. This is the big one. Lowest hanging fruit we have in the United States, lowest hanging fruit you have here in the state of Florida, jails and prisons. No doubt. You've got people in there right now, the vast majority of them are in there one way or another related to some kind of nonviolent drug offense in your counties and jails all over the state. We got to improve treatment in jails and prisons. We started a medication program in the Jefferson County Jail in Tennessee. That's about as rural as you can get. It's right before you go into the Great Smoky Mountains National Park. I had a judge and I had a sheriff, and that's all you need. And so now when you come into the Jefferson County Jail, we screen you. If you screen positive for SUD secondary to opioids, then we evaluate you. I do the evaluation via Zoom. If you qualify for medication or we think medication will help you, we start you on it. And then you have a hot handoff when you leave that jail into the community, and not with some place that's going to make you pay cash and treat you poorly. Somebody that takes your insurance, or if you don't have money, we have state opioid response dollars. We've been doing it 2 years now. In those 2 years, we've had about 150 patients come through. We've had 6 rearrests. 6. Recidivism rate in Tennessee, 75%. We've had 6 rearrests, and 5 of those were old charges. Only 1 new charge. We've had no overdose deaths. That's scalable, and you can do it. You need a sheriff, and you need a judge, and you need some jailers that you can work with, and that can happen. Fund warm handoff programs and recovery services from prisons and jails and hospital emergency departments. Right now, you can overdose, go into the emergency department, stay there an hour, and hit the door. And nobody says anything to you other than hand you a list of AA meetings and some numbers to call, half of which nobody answers, and the other half don't take your insurance. Guys, the system is broken. And some of these fixes I'm talking about aren't very expensive, but we got to be able to work together in order to do them. Housing. The number one need we have in the United States right now with regards to SUD is housing. And it needs to be stable housing. It needs to be supportive housing where people learn how to live life, learn how to do their laundry, right? Learn how to wash dishes, all of those things. Now, I'm not talking about just a place to lay your head. I'm not talking about a place where you go and just trade drugs. I'm talking about structured recovery housing, and we need to hold those places accountable. And I shouldn't have to tell anybody in the state of Florida why that's important. Because actually, most things bad that get started in the United States seems like they get started here now. I'm not sure why. But this was one of them. You had a housing mess here in recovery housing in Florida. You had multiple articles written about it. But then you got a guy down in Broward County, Al. And Al was a prosecutor, but he also had a heart for recovery. And Al started to clean this up across the state of Florida. And so Al's daughter goes to a school in Nashville now. So I'm hoping to con him into some things in Tennessee. We got to enrich prevention strategies, not dare. Dare didn't work. It's okay It's okay. Guys, when things don't work, it's okay. Let's just not do them. Let's not keep putting money into things that don't work. I'm not mad, but there are other evidence-based programs out there that we need to be looking at, investing our time and our money in. We have to support data collection and continuous quality improvement. I'm going to talk about that in my closing right here in just a minute. And then last but not least, transparency and involvement of people with lived experience. On our councils across the United States, we need people with lived experience. They have to have a voice. I can't tell you anything about jails or prisons because I've never been in them. We need some people that have come through the system that can help us navigate this, help us find the spots where we can start to save lives. That's what we have to do. Now, our Opioid Abatement Council in Tennessee has 15 members on it. Do you know how many people we have with lived experience on our council? Anybody? One, and that one's me, and I really shouldn't count. I didn't go through a normal system. We have one person with lived experience. We have one person of color. One. That's not going to get us where we need to be. We've got to have people who've lived it that can help us find our way out of it. So let's talk about this system of care for a second. I want to talk to you about something called systems dynamics. If you had a way to model a system and look at the money you were getting ready to invest in that system, plug it into your model, and then look at your outcome, that would be a pretty cool thing, because right now we're going to use the SWAG method as we invest money in all these things. You all know what the SWAG method is? Anybody? Scientific wild ass guess. So what if you had a way to take the amount of money that you have and model it, put it into the system, and look at what your outcomes are? Because what's our goal here? Our goal is to shrink the number of people who use drugs. That's our goal. We'll call it the stock. And into this stock, you've got an inflow. I'd like to think of it like a bathtub. You got a bathtub, you got water coming in, you got a drain going out. Okay? So you got the inflow, which is the new people coming into the system. You got the outflow, which drain people going out of the system, going out of this stock. So when you go out of the system, you got three possibilities. Number one, you're in recovery. Number two, you're bouncing back and forth. Number three, you die. Okay? So let's think about this for a second. If you had $100 million and you're going to invest it in your system and you put it all in Narcan, I'm going to spend it all in Narcan. And not a bad thing. We're saving a bunch of lives, right? What does that do to your stock over time? What's your goal? Your goal is to decrease your stock, decrease the number of people who use drugs. If you put it all in Narcan, that's the drain coming out. It's one of the three possibilities. What does it do to your stock? It increases it. More people are going to be alive. There'll be more people get into recovery, but there'll also be more people who bounce back and forth relapse. And you're going to, because you haven't done anything to address the inflow. You haven't turned the faucet off. So what if you had a way to look at your dollars and invest them throughout this system that gives you best chance to reduce your stock, and you use artificial intelligence in order to do that, machine learning. And I'm not a computer guy. I can barely work my phone, but I get this because I get the system. Would there be things that we discovered from an innovation standpoint that we don't even think of right now that could decrease that stock? And I'm telling you that there are. I'll guarantee it. And there's people out there that know how to do what I'm talking about. And we got to be brave enough, because the system doesn't want us to do that. The system wants to stay the same. The system wants you to keep investing your dollars in the same programs right now that you have been for years. And there's a great Einstein quote, right? You can't use the same thing. Well, you can't solve a problem by using the same things that got you into the problem in the first place. And we have to be looking at this. We have to be brave and bold in doing it. And I'm trying my best to do it in Tennessee, and I'm going to make the argument anywhere I go. Because if we can use these tools that we have at our disposal, we can create a system of care that no matter where you touch it, you get the treatment that's right for you, not what's right for the person, not what's right for the center that you're going to. And the other thing is this: if you have a predictive model and you invest your dollars and you're not getting the outcomes that you projected, really only two reasons for that. One is you guessed wrong, right? And two is you've got some kind of barrier that's preventing that from happening. And guys, we're never going to know that if we do what we do right now. And what I see right now all across the United States is people just investing in the same things they've done over and over, and not looking at these key metric outcomes and being willing to change money from things that aren't working to things that are. And I'm here to advocate for that, because I think we can save a lot of lives, because we're never going to have this kind of money again. It's not going to happen again. And if we're not careful, we're going to waste it. We're going to waste it. There'll be some lives saved, and that's good, right? But it's not going to be near the impact that we could have otherwise. So why is it important? It's important because of this. this is my most important slide. This is my family. That's Florence, Italy in the background. This is a few years ago. I grew up in rural Jonesboro, Tennessee. When I was a little boy, I was always put in the classes that were slower. I was a discipline problem. You all have known me now for about 35, 40 minutes. You could probably see that. I was a discipline problem. Whenever I got disciplined at school, they brought me around to the edge because we went in schools with partitions because some idiot thought that would be a good idea and didn't put any windows in our school. That's another story. And they brought me around to the edge so multiple classrooms could watch me get whipped. What was going on in my house? I was being physically abused by my mother. I was being sexually abused by my uncle. You can beat me all day long. You ain't ever going to get a tear out of me. To hell with you. We have to change our approach to that. It happens all the time. I was always put in the slow classes. And then in the 7th grade, we took a test. First year they ever gave it in Tennessee. They call it the TCAP now. But back then, we were the first class to take it. And a teacher came and got me out of the dumb class and put me in the smart class. And then I thought I was smart. One of the biggest things that ever happened to me in my life. I wound up going to college. I wound up going to medical school. And if somebody hadn't come out to get me, it would never happen. So it's those resiliency things that we've got to work on. We've got to look to identify for people who are at risk. And if we do that over a long enough period of time, we'll see big changes going forward. But politicians don't like this. Why? Because it doesn't happen on a 2 or 4 year election cycle. Okay, we're talking about downstream. So I took my family to Florence, and I know I've got a minute. I'm going to go a tiny bit over, but I'm still good. I got fired up. So we go to Florence. That's my son, Heath, my now daughter-in-law, Laura, my wife, Karen. That's me in the middle. I want to concentrate on the little girl to my right. That's my daughter, Haley. It's where all my money goes. Every dad in the room knows that when you have a little girl, you know at some point somebody's going to come and take her away. That's just a fact. And I knew that Haley's entire life. When it was Heath's time to go, it was time for him to go. I love him, but his ass need to go. Hey, Haley was a different story. I offered to pay for everything the rest of her life if she'd live in her bedroom. And so when she was a junior in high school, she brought that thing to her right on home. His name is Sterling. It was their first date. He was a senior. They were going to the prom. I sat on the front porch and waited on him. He walked up on my porch. He was driving a car. I said, my daughter's not getting in that car. I didn't know the kid. I gave him the keys to my car that night. At least if they had a wreck, they'd have it in my car and not that thing he was driving. And I walked in and I told Karen, I said, Karen, I just met this kid, and I think I just met our son-in-law. She said, come on, it's their first date. Right, they're juniors and seniors in high school. 6 years later, I'm standing at the end of a long aisle in Charleston, South Carolina, and it cost a fortune. And I've got my daughter on my right arm, and she's getting married. And I'm coming unglued. I am dying. And right before we walked down the aisle, she laid her head over my shoulder. She said, Daddy, you're the first man I ever loved. Thank you for everything you ever did for me. Not bad, right? Not bad. Great day. At the same moment, I knew that I was in the program that night, not in parentheses. Stephen Loyd, father of the bride. Not parentheses. What's in parentheses? Birth and death date. I'm May 11th, 1967, dash. I'm still a dash. I'm dash because I stepped into a system of care that was designed for me to be successful. I got to give my daughter away. My son got married pandemic year. In October. In April, Tennessee was closed down. The pandemic did a few good things. It took sports off TV, and it brought back the family dinner table. And so we're all having dinner one night, and Heath looked up at me in April, and he said, hey, Pops, would you be the best man at my wedding? Heath played college baseball. He's got 100 buddies. He asked me to be his best man. 2 most important days of my life up until that point were the day my daughter got married and the day my son got married, and I was there for both of them. I wasn't in the program as a 2 dates. Guys, that's why this is important. That's why we look at things the way we do. We got to look at it differently. We got to look at a way to effectively spend our money so that this picture happens more than it doesn't, because right now, this is the exception, not the rule. Right. I said 2 at the time because meet CC, Cecilia Ann, my granddaughter. She was born 3.5 weeks ago. This is why this is important. Nobody wants to wake up and stick a needle in their arm. People want a life. They want to provide for their family. They want to have kids. They want to have grandkids. It's why the work that we do and the things that we talk about are important. We can get up here all day long with numbers and graphs and, studies. Nobody gives a shit about that, right? This is the deal. This is the deal, and it's why we're here. With that said, thank you all. Thank you. I'm sorry. Thank you all. So we did leave time for questions. We got started 7 minutes late, so if we have 7 minutes, we can do questions.
Please.
And I'll be glad to entertain anything you guys have. Yes, sir.
Dr. Loyd, thank you so much. I've seen the movie, and you are just wonderful. But I want to know about housing, okay? And so I'm a housing provider, and so we've been looking at the whole kind of substance abuse arena. Give me 3 things that are going to help people be successful. We provide the housing. What is it that's working, and what's not working?
Okay. So the thing for sure that's not working are barriers to housing. I mean, that's not working. So the first thing I would tell you, and I've got plenty of people that I can, get to refer you to who can help you more than me because I'm not a housing expert. But the barriers to housing, the big one being medication. You don't need to keep folks separate. They don't need to be separated from the general, from other people. Medication is just a tool like anything else. So I would tell you to for sure entertain the idea of having medication in your houses if that's what people need to stay in recovery. And I'll tell you this, in my own treatment, the guy who helped me, his name was Chip Dodd, and we lived in houses, and we're all grown men. And we didn't have women in our treatment center. It was all men. And he told us, he said, you all will get more out of your time living together than you actually do here in active treatment. I don't believe all of that, but I believe a lot of it, because when we went back to our houses at night where we all lived together, that's when recovery started to happen. We started to learn how to live in relationship. And so one of the things that caught me right off the bat was I was spoiled. My wife did everything for me. I didn't know how to wash my clothes. I had never washed dishes. I hadn't done anything. Well, I got in there. Well, hell, you got to do something. They let me cook one night. That was it. But I did dishes. And now when we eat in Johnson's, we eat in Nashville, I do the dishes. I still do it 19 years later. So it's more than just a place to live. It's structured housing. What are these things? Making your bed when you get up in the morning, having your bathroom where the things you use to groom yourself in the morning are all in the place that they're supposed to be, and keeping things neat where they're supposed to be. Most of these folks have never had anybody do that. And I know this sounds simple, but start there. And when I look at that, and then the last thing is this, a time in the evening that everybody gets together and talks about their day, right? Circle up, man, what happened today? Because this is what we all do in this room. When anybody asks y'all how you're doing, how do you respond? Fine, right? Fine is not a response. That's crap. Right? We all have stuff happen to us in our day that causes us angst, that causes grief. And so a checkout period every night before we go to bed is a really good thing. What are the things that happened in my life today? Well, I got into this argument, that argument. Now you can start to put some of the principles of recovery in place. Maybe I didn't handle that as well as I did. Taking feedback from your peers. To me, those were the important things in housing. It wasn't just the fact that we had a place to live. Now, that was good, but it was these relationship things that we developed as a community. And I would love to see that be more structured, because you all know as well as I do. If you just say, okay, you all come down and, before you go to bed tonight at 9 o'clock, come down and talk about things if you want to. That won't work. 9 o'clock, guys, we're going to gather up and we're going to talk about our day, see how things went, and set a time limit on it. We're going to do it for 25 minutes. And at the end of that 25 minutes, get up and go to bed. All right? And then I got one more for you. You got to have a routine. Most of the people out there who, my patients all tell me when they're scamming and hustling, okay, I don't use that, they do. They don't have a routine. Sleep is going to be a huge issue. Oh, I can't sleep, I can't do this, can't do that. And so if you don't know what you're doing, the next thing you know, you've got them on a benzodiazepine, which is addictive, and now you go down that route. Talk about a bedtime routine. Talk about a bedtime routine. Talk about getting the TV out of your bedroom. Talk about not looking at blue light, before you go to bed. Blue light affects the production of melatonin. Melatonin is what causes you to go to sleep at night. Things that you can do from a general living standpoint. I like to think of it like this. About the same things you try to teach your kids. Pretty close. And that's my recommendation. You can go out there. NAR is out there. You know what NAR is. Florida will have their equivalent of that. You'll have these certifying organizations. I'll tell you, we start with the basics of living, just like I said, because those are the things that help me. Anybody else? Yes, sir.
Dr. Loyd, you talk about peers and you call them the secret sauce.
Yes.
I wonder if you can talk about why they're secret and why aren't they, if that's the secret sauce, why aren't they promoted?
Gosh, I have no idea. They shouldn't be a secret. They absolutely shouldn't be a secret, but I see very few people utilizing them. So what we looked at in Tennessee is that my practice, Cedar Recovery, we target Medicare, Medicaid, and uninsured. That's who we go after. And if you look at Medicaid reimbursement for a peer, they actually started reimbursing for it. $8 every 15 minutes. So if you work them 4 15-minute slots, don't get a break, what is that, $32? And you can't pay salary and benefits for $32 an hour. And that was the big pushback from our board for the longest time. But I knew better. So what we did was, in outpatient treatment, the secret to long-term success, there's only one positive predictor for long-term success in outpatient treatment. What is it? It's not urine drug screens. It's not compliance with therapy. What is it? It's retention and treatment. The longer you stay, the better you're going to do. So what we saw is we map our patients from the time they first call us to they show up in their office to they come to their second appointment all the way through. We know when we lose them. And so the idea that we had was we're going to take 2 of our practices, and the second the patient makes a call into our office, not when they show up, they make the call, we're going to hook them up with a peer support specialist that day. And we're going to build that relationship all the way through the first year of their recovery and see what our retention rates look like at the end of that time compared to our other practices where we don't do that. And it was overwhelming. It was absolutely overwhelming. And really, that shouldn't come as a shock to any of us. Those people in that little rural county I was talking about, nobody cared anything about them. And they knew it. And it pissed them off. And they came at me with it because I had the guts to show up and let them talk to me. Whenever you have a relationship with somebody, that's different. Guys, the opposite of addiction is not recovery. The opposite of addiction is community and relationship. And I think that that's the reason. It's the nearest I can come up with, and we've started hiring them by the boatloads. Also, people with lived experience need jobs in their own recovery. Right? Try going out and getting a job like Brooke did with a couple of felonies hanging over your head. What if going out and getting a job and your addiction was the main selling point? Your own experience. Right? So we're providing employment opportunities for those people in recovery. Yes, ma'am.
Dr. Loyd, this is more of an impact statement. As a certified peer recovery specialist, 6 years ago today, I did overdose. October 28th, I did because of LSF and a group called Epic Behavioral Healthcare, because I did get kicked, my insurance did keep kicking me out. Then I got kicked off of parents' insurance, hopeless drug addict, covered still in my lovely track marks. But because of LSF, because of nonprofits, I was given a chance at hope. Because of Epic Behavioral Healthcare, I'm alive today. Because of LSF, I'm alive today. Because of LSF, I'm a peer today. I did my trainings. I was the first ever client of Epic's to receive a Vivitrol at $1,600 a month. Dope people like me, or heroin addicts like me, don't have $1,600 a month. Although I can, hustle money for drugs, right? But because of that, I'm standing here, and because of you and what you said, it's all true. I'm living proof. And today I do save lives. And today, because I have the lived experience, because I have the track marks all over my body, people are open to come to me because they're like, you get it. How did you do it? If you had told me that like 6 years ago today, when I was loading up that lovely shot that I would be here today, I'd be like, okay, like it's a joke, right? But October 28th, something snapped. October 28th, I found out about a nonprofit that did have inpatient, then outpatient. I still see my counselor that I met at Epic 6 years ago. I connect people with services. I tell them, hey, there is funding for you, there is help. So thank you so much, because everything you said is true. So thank you.
Thank you. I always know you're out there, right? Always in any audience. So thank you for standing up and saying that. And guys, when I was an internist working in the hospital, I went up or down on somebody's dose of blood pressure medicine and gave them an antibiotic. Hell, I don't know if I ever did anybody any good. I get to see that all the time. And that's living proof right there, because I don't think any of us would have walked in there and went, all right, no way. Thank you. All right, guys, with that said, thank you all so much. I appreciate your time. Thank you.